This is about eye trauma. We will mainly talk about chemical injury and blunt trauma. In blunt trauma, you can get ruptured eyeball, hyphema, and blowout fracture. In chemical injury, remember that alkaline is worse than acid because of the saponification process that damaged the ocular tissue. Examples include bleach and also lime in the construction site. Acid is also dangerous but might not be as bad as alkaline because it causes coagulative necrosis, and that actually stops their own process of damage. The key is to perform irrigation until neutral pH, and this cartoon shows you the setting. So the steps are: test the pH, apply topical anesthetic eye drops, insert a speculum, and irrigation. Remember to retest the pH after around 20 minutes of irrigation, or else you will be testing the irrigation fluid. You must also remember that you do not use acidic solution to neutralize the alkalis, because the reaction actually causes more harm. You should also perform double slit inversion and make sure that you remove all the particles in the eye. You should refer the patient to us. We will retest the pH and also perform a comprehensive assessment to look for complications of the chemical injury. This is a list of what we will look for during examination. You don't need to remember the whole thing. We particularly look for limboischemia. Now, in limboischemia, the vessels are blenched without visible blood flow. Permanent damage to the limbus is a poor prognostic indicator because the limbus contains stem cells for regeneration of the epithelium. It also acts as a barrier between the conjunctiva and the cornea. You don't have to remember the whole list of complications. Just think about them one structure after another. For the conjunctiva, permanent damage causes keratinization and symblepharon, and actually you see similar complications in Stevens-Johnson syndrome. If the limbus is permanently damaged, the cornea becomes opacified, and the conjunctiva also, if you like, start invading the cornea. Full thickness burn can damage all sorts of structures. Of course, periorbital burn should also be in the list. We now move on to blunt trauma. This could happen in road traffic accident, hit by a football, tennis ball, or even a badminton shuttlecock. Look at the diagram and see how the force can be distributed. In blunt trauma, look for other associated ocular injury, ruptured eyeball, and orbital fracture. Also, check for head injury. So you should take a very good history, explore the mechanism of injury, any other associated injury, and inquire about the tetanus status. Also ask about symptoms of increasing intracranial pressure, including headache, nausea, vomiting, diplopia, and also explore the consciousness of the patients. Now for the examination, you must look for signs of ruptured eyeball, blowout fracture, and other alarming ocular injury. So check whether the patient is alert or not. Look for external signs, including ecchymosis, bruising, lid swelling, ptosis, enophthalmos, and strabismus. You should look for signs of skull-base fracture as well, such as recurrent eye. If you want to be helpful, you should check the visual acuity and also look for RAPD. Palpate the orbital rim for crepitus, tenderness, and bone step off in case of orbital rim fracture. This is not common because the orbital rim is actually very strong. Now check the cranial nerve. Particularly look for the eye movement and diplopia. Also suggestive of muscle entrapment if there's up gaze or side gaze restriction. Palpate the infraorbital region for numbness, indicating infraorbital nerve involvement and suggestive of fracture orbital floor. Now notice that some orbital swelling could be so bad that you can't open up the eye. Try not to force open the eye, leave that to us. And for us, we would do slit lamp examination, intraocular pressure, fundal examination, and also use what we call exophthalmometer to look for proptosis or enophthalmos. These are the signs that you look for in the blunt trauma. Again, you don't have to swallow the whole list, just go through the anatomy. For the cornea, there could be epithelial defect. For the anterior chamber, you may see cells, hyphema. Now, if the iris is irregular, you have to be very careful about ruptured eyeball. Now, for the lens, there could be subluxation, there could be dislocation. For the vitreous, there could be posterior vitreous detachment and hemorrhage. For the retina, all sorts of things can happen, including retinal tear, retinal detachment, retinal dialysis, choroidal rupture, and also what we call a commotio retinae, meaning fragmentation of the photoreceptor and intracellular edema, and these usually resolve by itself. Now, for the optic nerve, you worry about traumatic optic neuropathy. Intraocular pressure could be high or low, depends on whether there is any ruptured eyeball or presence of high femur. And for hypotony, you have to be very careful. Now, for periorbital signs, we've already gone through some of these. The important thing to look for is the signs of ruptured eyeball. These are the signs that points towards ruptured eyeball. Obviously, if the eye looks, if you like, deflated, or if you see intraocular contents sticking out, then those will be quite obvious. Otherwise, you look for the following: extensive subconjunctival hemorrhage, especially if there's 360 degrees of bulbar conjunctival hemorrhage that looks very swelled up. Then you worry about a posterior rupture. Now, for posterior rupture, the common site of rupture is actually at the sclera, just posterior to the attachment of the rectus muscle, because it's the thinnest part of the globe. Other signs include a flat or shallow anterior chamber compared to the fellow eye, a peaked irregular pupil or iris prolapse, lens material or vitreous in the anterior chamber, limitation of extraocular movement greater in the direction of the rupture, and also low intraocular pressure. Now, if you think it's a ruptured globe, stop everything and try not to put any pressure on the globe. Then you make an urgent consultation to the ophthalmologist. Provide an eye shield for the patient, but do not patch the eye. Okay? Provide tetanus prophylaxis if necessary, and also provide antiemetic if necessary, systemic antibiotics, bed rest the patients, and prepare the patient for emergency operation under general anesthesia. The ophthalmologist will also book a CT orbit for the patient to rule out intraocular foreign body and also presence of any fracture of the orbit. Another important complication is high femur. That means blood in the anterior chamber. Now, there are two important points that I would like to make. First of all, if the high femur persists with raised intraocular pressure, you worry about corneal stromal blood stain, which could lead to significant visual loss. In those cases, we need to intervene. Secondly, high femur could reflect an underlying what we call angle recession, which means a permanent damage to the aqueous drainage system, and that could increase the risk of glaucoma. So ophthalmologists need to check for that. Management is pretty much similar to ruptured eyeball. Now, notice that high femur could actually happen spontaneously if the patient has neovascularization of the iris. In a blunt trauma, there is a sudden increase in the orbital pressure, so the pressure can fracture the weakest bone. And the common site includes the orbital floor and the medial wall. The two can actually happen together. The lateral wall and roof are rarely involved because of the thicker bone. These are the signs in orbital fracture, and they reflect the extent of damage. In orbital emphysema, the air comes from the paranasal sinuses after fracture of the medial wall. Proptosis could reflect an underlying retrobulbar hemorrhage. Anophthalmos if the globe sinks into the fracture hole. Infraorbital paresthesia indicates infraorbital nerve involvement, and therefore orbital floor fracture is likely. Muscle entrapment could also occur in orbital fracture. Fracturing the floor and entrap the inferior rectus, you get an up-gaze problem. Fracture the medial wall and entrap the medial rectus, you get a lateral gaze problem. So diplopia. Now, transient diplopia could also occur if there is orbital edema and hemorrhage without blowout fracture, and also that could occur in cranial nerve palsy. As I said, fracture of the orbital rim is not common. Again, you refer the patient to us, tell the patient not to blow the nose, and provide systemic antibiotic prophylaxis. We will then order orbital CT scan to delineate the lesion for the patients. Now, not all fractures require surgery. However, immediate repair is required for muscle entrapment, especially in children if they have ocular cardiac reflex. That could lead to bradycardia, heart block, nausea, vomiting, and syncope. Now, early repair is required if there is persistent diplopia in primary or down gaze, and also large orbital floor fracture. Late repair is possible if old fracture leads to anophthalmos. And that's it. Thank you.